We're with the second cohort, the 2024 class of the Diabetes Doc program participants, and we showcased part one of the group on Tuesday, and today we're very lucky to have with us Kathryn Fantasia. She's an MD MSc, Daniel Tilden, and he's an MD, and Jacob Kohlenberg, also an MD. So we're going to, have each of them talk about their work a little bit, and I will introduce each of them just prior to their presentation. So first, for Dr. Kathryn Fantasia, she's an MD MSc, as I mentioned. She's a board-certified endocrinologist at Boston Medical Center, and she's an assistant professor in endocrinology, diabetes, nutrition, and weight management at BU's Chobanian and Avicii School of Medicine. She specializes in caring for patients with type 1 and type 2 diabetes, as well as treating other general endocrinology issues, and her research centers on diabetes care and outcomes, as well as diabetes technology use. She received her medical degree from Albany Medical College and a Master of Science in Health Services and Systems Research from Boston University School of Public Health, and we're very excited to hear her presentation today.
Thank you so much, Monica. Thank you for the opportunity to share with you my work. I'm also really excited to be here with my colleagues and to hear updates on their research as well. One of the best things I think about this K12 program has been getting to know other early career researchers who are as passionate about diabetes care and diabetes research as I am. I'm just going to go ahead and get started, and I'll be sharing with you today about my work developing a culturally tailored diabetes technology education program and materials for Black and Hispanic adults with type 1 diabetes. So to frame the problem for everyone, it is by now well documented and well known that there are disparities in diabetes care and outcomes, and that Black and Hispanic people with type 1 diabetes are less likely to achieve glycemic targets and more likely to have complications than white people living with type 1 diabetes. And we also know that the use of advanced diabetes technologies, such as continuous glucose monitors and automated insulin delivery systems, are associated with improved glycemia, improved quality of life, decreased complications. Unfortunately, despite these benefits, Black and Latino people with type 1 diabetes have lower rates of advanced diabetes technology use, and the lowest rates within racial and ethnic minority groups are actually seen in Black adults, and that data comes from the Type 1 Diabetes Exchange. These inequities have been demonstrated in multiple data sources. So here on the right, I have a graph from the T1D Exchange registry from their updated data published last year, specifically looking at AID use. And what you can see is that automated insulin delivery use is 1.5 to 2.4 times higher for, I don't know if you can see my pointer, but 1.5 to 2.4 times higher for white people living with type 1 diabetes. Than for Hispanic people living with type 1 diabetes, that's the orange line, or for Black people living with type 1 diabetes, that's this blue line here on the bottom. And like I said, this has been demonstrated in multiple data sources. On the left here, I have data that I published several years ago now, so this is older data, but similar trends were observed. Black adults living with type 1 diabetes used diabetes technologies at about half the rate as white adults, and we saw these differences even after adjusting for sociodemographic factors like language and insurance and income. So we also know that there are multiple drivers of inequities in device use. It's not just one thing that contributes to the inequities we see. And this is not meant to be an exhaustive summary, but I've organized some of what we know about the determinants of device use according to the socio-ecological model, which is a way for us to think about contributors to a health outcome or a practice. And so we know that there are policy barriers, so insurance coverage barriers that influence device use for people living with type 1 diabetes. It's also been shown that there exists clinician bias against public insurance coverage, and people from minoritized racial and ethnic groups oftentimes have public insurance. We know that there is a perception from patients, and it's probably well-founded, that clinicians act as gatekeepers of information and prescription access to technology. And more recently, what's been identified in a qualitative study of Black adolescents with type 1 diabetes and their caregivers, and in my own preliminary research that led into this K12 work, limited exposure to others wearing devices and living with type 1 diabetes, and limited and inadequate information sharing on devices. I think the other really important thing to know about what we know is that most of this research has been done in young people, so youth, adolescents, and young adults, or in white adults. And there are gaps in our understanding of what the determinants of device use are for adults who come from racial and ethnic minority groups. So to investigate the barriers and facilitators to use of CGM and insulin pump therapy in minoritized adults in the urban safety net setting, I previously conducted a qualitative study of clinicians and patients living with type 1 diabetes who did and did not use devices. And what I did was I used a model that comes from behavioral research called the COM-B model, which is the capability, opportunity, and behavior model to understand device prescription and use. And this model is part of a larger framework called the Behavior Change Wheel, which is a synthesis of 19 frameworks of behavior change, including the Theoretical Domains Framework, which is a framework that can help us understand and change clinical practice. But basically, the model recognizes that behavior is part of an interacting system where capability and opportunity can influence motivation. And all of those things, capability, opportunity, and motivation, have a reciprocal relationship with behavior. So what I did was I conducted semi-structured interviews with people living with type 1 diabetes who did and did not use devices and who received their care in a safety net endocrine center, and with clinicians, diabetes clinicians in a safety net endocrine specialty clinic. And then I organized my analysis around these domains: capability, opportunity, and motivation, basically to understand the behavior and to identify actual and potential strategies that may increase device prescription and use. And so I'll just touch on this really briefly because it's what fed into my K12 work. But basically at the clinician level, sort of in the domain of opportunity, I identified that clinicians believe it's their role to communicate the benefits of devices and to raise patient awareness about devices. However, they often lack sufficient time and need additional resources to do so. And additionally, staff with designated roles and responsibilities can help overcome insurance barriers and to help train patients on use, and therefore can help support use. And so this is just an illustrative quote from a physician who said that I guess it's partly education, and she's talking about sort of what drives prescribing of devices. Patient education, and again, time sometimes is the limiting factor. In the clinic, it'd be nice to have some pamphlets about the benefits of the insulin pump, and when time is short, to give the information. And then at the patient level, we identified that conversations initiated by clinicians are often the first and often the primary source of information about devices for these people living with type 1 diabetes, and also that sufficient information sharing related to benefits and safety, in particular, device trialability and preferences, can impact an initial decision to use an insulin pump. And so this is a patient, or a person, sorry, he was a participant, who said, years ago, I had opportunities where they offered the pump. I was wary about sticking the pump inside of me, and I didn't really get it too much. I was still always skeptical about it, not understanding it. How would it affect you? It was just a lot of things that we really didn't get the questions to ask, but I had it on the back of my mind. And this was a Black man living with type 1 diabetes who did not use any devices. So my conclusions from this initial qualitative study were that using a strategy of creating new teams with defined roles and responsibilities was a primary strategy that had helped promote prescription of devices, but I also concluded that patient-facing educational information on AID system use could potentially be a helpful strategy, as it would target several of the determinants to device use. So in particular, clinician lack of time and need for resources, and increasing patient awareness to information about safety and benefits. And I will say that, as I mentioned earlier, these findings aligned with a similar qualitative study that had been done in Black adolescents with type 1 diabetes and their caregivers, which found that inadequate patient-facing education provided by a healthcare team is a potential driver for inequity in device use. So in thinking about patient educational materials about devices, I turned to literature, and specifically thinking about how do we communicate, concepts around safety, benefits, supports for use, indications for use, candidacy. I thought about just generally patient-facing educational information, and specifically because I'm interested in reducing health inequities and promoting health equity, I looked to the literature on promoting health equity in other chronic conditions. And so it's been recommended that cultural tailoring be integrated as a method to improve the relevancy of educational materials. And what this is specifically is the tailoring of an intervention, like a strategy, a message, or materials that's informed by cultural attributes of a population or community. And this can be informed by like values, traditions, history, beliefs, or just practices in a community. And the use of cultural tailoring strategies has been recommended both by PCORI and the National Quality Forum as a method to reduce disparities. And there actually is already evidence for the benefit for culturally tailoring chronic disease education for Black communities. So there's evidence for benefit in type 2 diabetes prevention and management, and also cardiovascular disease. And there's some evidence for benefit of cultural tailoring of type 1 diabetes education and programming, but most of this work has been done outside of the United States. And there are a couple of different strategies that can be employed to enhance cultural appropriateness. And this comes from PCORI, but the strategies that I've been using in my current work are linguistic and constituent involving strategies. So the overall sort of like objective of my K-12 work has been to develop and test culturally tailored diabetes technology education materials and a clinical program for the delivery of the education materials for Black and Hispanic adults with type 1 diabetes. And my hypothesis is that co-designed culturally tailored diabetes technology education materials and a clinical program are both acceptable and will improve device uptake among Black and Hispanic adults with type 1 diabetes. So my overall proposal and study has been guided by an established model for adaptation that comes from implementation science, which is the study of how to get evidence-based things into practice. And what I've done is I've used the ADAPT guidance, and this includes development of an adaptation team and collaboration with those with relevant experience and expertise in determining if adaptations need to be made and what adaptations need to be made to a program or an intervention. And so here I'm collaborating with Black and Hispanic adults with type 1 diabetes and clinicians who care for adults with type 1 diabetes in safety net settings to gather through qualitative interviews, narrative experiences with diabetes care and technology education to assess currently available educational materials for their appropriateness and the need for adaptation, and also to identify optimal processes and features for a program to support minoritized patients in receiving technology education and diabetes care. I'm using cognitive interviewing procedures to review the educational materials and to understand decision processes around device use, and to also assess the educational materials for potential adaptations. So just briefly, a few words on co-design to explain this a little bit more. So co-design is a method that's been used across both the health and the public sector to increase acceptability of an innovation. And it's a participatory form of research or program or product development that can describe, truthfully, a pretty broad heterogeneous set of practices. But here, what I'm specifically doing is I am collaborating, and I'm using this term to describe a collaboration between myself. I'm an academic researcher. I do not have type 1 diabetes, and the end users of a program and materials to draw on the lived experience and expertise that they have to design a program together. And I also want to take a minute to acknowledge and say a very, very big thank you to Corey Hood and Ann Peters. They have been extremely gracious, and with their permission in this study, I'm specifically using the Diabetes Wise patient-facing sensor and smart pump device guide, and is the insulin pump right for me simple guide for patients as the patient-facing educational materials that I'm assessing for need for adaptation with Black and Latino adults living with type 1 diabetes. So I've completed enrolling patient participants, and I'll share with you that data today. So I completed interviews with 22 people living with type 1 diabetes. Because I'm specifically interested in identifying strategies to promote earlier device use and device use among people who are, not achieving, glycemic targets, and specifically for people who come from racial and ethnic minority groups. Participants were eligible for the study if they were Black, Hispanic, English-speaking, or Spanish-speaking, and if they had a diabetes duration of less than 5 years, or if their A1C was over 9%. So half the cohort was female, half was male. The median age was 36. The median diabetes duration was 5.5 years. And you can see the interquartile ranges listed there. The median A1C was 9.7%. Half were Black, half were Hispanic. 15 people spoke English as their preferred language, and 7 spoke Spanish as their preferred language. So I'll be sharing the preliminary results from the interviews with the English-speaking Black adults with type 1 diabetes, because that's the data that I've finished analyzing. I haven't quite finished analyzing the data from our Hispanic participants or the clinicians yet. But from our interviews with Black participants, we've identified 3 preliminary themes. The first is that a mistrust of devices and concerns specifically about automated insulin delivery system failure impact a decision for use. So this is a quote from a Black woman living with type 1 diabetes for the last 7 years who uses a CGM. And she said, "I heard about the insulin pump and it's a no thank you to that because I don't trust it because it might malfunction, it might overdose me." And second, and I think relatedly, is that detailed information on AID use, specifically the benefits, the risks, and troubleshooting device failure would help to facilitate a decision to use an AID system, particularly in the setting of device mistrust. So these 2 quotes come from participants during the cognitive interviewing portion of the study, where I'm using cognitive interviewing procedures to try and understand decision processes as it pertains to the use of insulin pump therapy and AID systems in particular, and also how people are comprehending and interpreting patient-facing educational materials. So in response to viewing the patient-facing education materials, this Black man who uses a CGM and has lived with diabetes for 1 year said, more detail on how it performs as a machine. Like, where is it going to go? How is it entering? It showed me all of that so I can imagine the whole thing. And this Black woman who also uses a CGM and has lived with diabetes for 1 year said, "It kind of opened my eyes to try and maybe try it. The information opened my eyes more to how it works." So thinking about that idea of the impact of information on decision making. And lastly is that support from peers living with type 1 diabetes, including opportunities for group education, specifically early after diagnosis, to help navigate the challenges of a type 1 diabetes diagnosis and to support device use is desired. So these are 2 participants. One of my questions sort of in the co-design portion is I ask people how they would design a program to support other people living with type 1 diabetes and support them in device use. And this Black man who uses a CGM and has lived with diabetes for 19 years shared, "If I were to design a program, you definitely need people that are just diagnosed. Dietitians, obviously, people that's going to instruct us. New technology. They can get a handle on that quick, and they don't have to be like me, having all this time and just now taking advantage of these new technologies." And a woman who had lived with diabetes for 3 years and was using a CGM shared, "I really like the class that I took, but make it more specific to people with type 1 diabetes, letting them know their options when it comes to devices. I would stagger things a little bit more than just bombarding someone with information all at once, but I think presenting the option for the pump a little bit earlier. Also, some sort of support that isn't necessarily medical, just with dealing with the fatigue and, despair, like a support group or something that would meet once a month." And so as I said, I'm finishing up analyzing the qualitative data from our Hispanic participants and completing the clinician interviews and analysis. But once these results are finalized, they'll be shared back with the participants for feedback, refinement, and closure. And then adapted educational materials and this co-design program, which I think will feature prominently a component of peer support and group education based on what I'm seeing from the Black participants, will be pilot tested in the adult endocrine clinic at Boston Medical Center for acceptability and feasibility, and also to explore changes in device uptake and glycemia for participants who enroll. And with that, I want to say thank you for the opportunity to share with you about my work, but I also want to say a really big thank you to my mentorship and research team at Boston Medical Center, without whom this project would not have been possible and this research would not be possible. And also a big thank you to the DiabDocs K12 program, to my external mentor, Marissa Hilliard, to Linda D'Amelio and David Maas and Komal Tasani. And with that, I'm happy to take questions.
Yeah, we're happy to have people drop questions in the chat.
And I can also
Great
stop share.
presentation.
Thank you.
So important. I had a quick question for you. I wondered, what percent of those with type 1 are Black or Hispanic adult patients?
Yeah, good question. I can tell you that in the it's sort of a hard question to answer because some of what we know about this comes from the type 1 diabetes exchange registry, which is not reflective of the overall general population, right? This is people seen in specialty care.
Yeah.
But what we know from the T1D exchange registry is that overall, about 14% of people are Black in the T1D exchange registry, and 11% are Hispanic. In our Boston Medical Center cohort, which again, slightly different because we are an urban safety net institution, and urban safety net institutions historically care for greater proportions of people who come from minoritized communities. In my 2021 study, about a quarter were Black and 15% were Hispanic. Those numbers are a little bit different now, and about half of our patients come from a minoritized community. And then we have there was a recent research letter published in JAMA that gave us the prevalence. And again, this is self-reported type 1 diabetes, but we know the prevalence of type 1 diabetes in adults from different racial and ethnic groups, and it's highest in white people at 5.9 per 1,000. And then in Black adults, the prevalence is, I think, like right around 5. And then in Hispanic adults, it's about 4 in 1,000 is the prevalence. But it's actually like a harder question to exactly answer than you'd think. So I don't know. I hope that sort of gives you an opportunity.
No, I just was curious because it does seem that there's, that's definitely more than historically I've seen in the numbers. So you wonder, is this increasing in those communities? And definitely the work you're doing to support them is needed. Anyway, but if they are increasing, if these populations are increasing, for sure, it's needed. I
Oh
guess,
yeah, yeah, exactly right. The prevalence is increasing. You're exactly right. And then I see
Yeah.
someone, Alexis, dropped in the chat the research letter that I was mentioning. So yeah, thank you.
Great, thank you. And then I just wondered, as you're talking about, Black adults, how are Black pediatric patients doing? Are they adopting more readily? And is
Interesting
it just
question.
because the tech savviness of that younger generation?
Yeah, it's a good question. So I don't know if it's because of increased sort of like digital nativity is like the term that I've been using to describe that, like tech savviness.
That's
But
a good one.
In the T1D exchange paper, I was just rereading it to refresh myself on the data for this talk, and there has been, I think, increased use, and I'm not a pediatric endocrinologist, and so this is sort of outside of my scope. So someone who is better versed in this data can definitely correct me, but it does seem like there are greater increases in pediatric populations. And there's also, in terms of improvement in glycemia, really exciting data that came out of the exchange. We showed that A1C curve that's like, the wave, the median A1C had shifted down from the last time that data was reported, and the biggest change in A1C was actually in I think in young adults. Granted, they have the highest A1Cs, but it's a good question. And if anyone else on the call is a pediatric endocrinologist or knows the pediatric data better, I would love to be corrected, or if there could be a clarification. But I think that there's been more headway in pediatrics, also because a lot of the research that's being done is being done in the pediatric space.
Right. Well, it's great. It's great that you're pushing this forward, and very important to share with the larger community and sort of showcase the work that T1D Exchange is doing and how you guys at Boston Medical Center are really partnering with them. It's really great, a great collaborative space.
Thank you.
So thank you again. And I'd love to talk more, but at the interest of time, let's go next to Dr. Tilden. Daniel Tilden is currently an assistant professor at the University of Kansas Medical Center, KUMC, in the Division of Endocrinology, Diabetes and Genetics. He completed fellowship in pediatric and adult endocrinology and metabolism at Vanderbilt University Medical Center. He earned his medical degree from the same Vanderbilt, and he completed his residency and fellowship at Vanderbilt. Dr. Tilden has a unique background as a former high school science teacher in rural North Carolina from 2008 to 2010, and he was as well as subspecialty training in both pediatric and adult endocrinology. And his research focuses on developing and implementing interventions to improve outcomes for adolescents and young adults with type 1 diabetes living in rural areas. Thank you so much for joining, Daniel, and very interested to hear your presentation.
Yeah, thanks so much. I appreciate the introduction, and hopefully we can continue some of the conversations we were just having as we talk a little bit more about adolescents and young adults with type 1 diabetes who are living in rural areas. So first, before we move on, I wanted to just acknowledge, a lot of the work that I do is out in these rural spaces that are beautiful, and we owe a debt of gratitude to the people who came before us, including the native tribes and peoples who live in these spaces. So the name Kansas, where I'm from, comes from the Kansa people who were living in these spaces and were great stewards of the land, as well as many other native tribes. So wanted to talk today first, dovetailing nicely with what Kathryn was just talking about, why I think it's so important that we focus on adolescents and young adults with type 1 diabetes. Transitioned then to talking a little bit about the sort of current state of what we know about rural type 1 diabetes care, talk about the work that we're doing currently with the K12 and our plans moving forward. So wanted to start first highlighting some of the things we were just talking about. So, it is important to talk about young adults and adolescents with type 1 diabetes because they make up the majority of patients. So among adult patients with type 1 diabetes, those under 44 are nearly 2/3 of that population. And as we were just saying, the incidence and prevalence of type 1 diabetes continues to rise across racial and ethnic groups with among those with type 1 diabetes. And so this was the graph that Kathryn was just talking about, which just shows the disparities that young adults and adolescents really experience among those with type 1 diabetes, with increasing the highest rates of diabetic ketoacidosis, hospitalizations, and glycemic outcomes, which result in the highest average hemoglobin A1C among any age cohort in the adolescent and young adult period. In addition, this is data that comes from a national insurance cohort. We know that this transition, as both a pediatric and adult endocrinologist, this is really something that has been the focus of a lot of my work. This transfer of care, transition of care between pediatric and adult care is a time that's unique to the experience of adolescents, people who are diagnosed as children, who are moving across to adult care. What we can see in these data is that as pediatric endocrinology and subspecialty care, along with primary care, as those visits decline, we see an increase in adult care appropriately. But what these data found was that while roughly 1 in 5 16-year-olds with type 1 diabetes did not see an endocrinologist, that rate rose to nearly 41%, who were being managed, whose type 1 diabetes was being managed without the involvement of a diabetes specialist. And so this really is important, especially with recent data that came out from Shivani Agarwal, who's actually my arm's length mentor in the DiabDocs program, who recently published the results from her SEED program, which is a young adult transfer acceptance program that they've been using it at her clinical space there, where they have really developed a team-based approach to addressing and increasing uptake of diabetes device use, like Kathryn's talking about, as well as really providing wraparound support and tailored care for the young adults in their population. And with those additional supports and that subspecialty care that she's able to provide, we see increased rates of technology uptake and a concomitant decrease in hospitalization, even when compared to people who are seen in the same medical center, but just not with that specialized care. And so I think this data taken as a whole really shows us that there's a gap, that subspecialty care for young adults is particularly important, and that they have an additional need for us to take into account and address both technology and psychosocial aspects of diabetes care, and that this is a cohort that desperately needs these additional supports to be able to achieve the outcomes that we hope for that are going to mitigate both short and long-term complications. So now to shift a little bit to focus on the sort of state of the art and what we know about young adults who are living in rural spaces within the US. So first, just sort of an overview of the rural population of the United States. Approximately 20% of Americans live in rural areas. When we look at the availability of endocrinologists, we see that roughly 15% of adults and 36% of children live more than 20 miles from an endocrinology provider. And so this is a sort of a visualization of the distribution of endocrinologists, and you can see that maybe obviously it's heterogeneous across the United States. And so those areas that are shaded in the darker blues, and those counties that are outlined in red, 100% of the adult population has access within 20 miles in those areas, where those are in white or in the lighter colors have either no access in white, or the lighter colors have lower percentages of the population with access to endocrinologists. And so we know that these geographic barriers are going to cause young adults to seek care outside of these specialty providers for sort of obvious reasons. But physical distance is just one aspect of rurality that may lead to additional difficulty achieving standard of care diabetes care. So alongside that physical distance to providers, we also see decreased access to other important aspects of diabetes care, including diabetes educators and nutrition therapy. There are also barriers to reliable internet connectivity, which with the rise of technology is particularly important for these patients. We also see difficulty with reliable and timely durable medical equipment refills, which is sort of where most patients are getting their technology supplies, and decreased availability at local pharmacies of these sorts of diabetes technology. And then we also see higher prevalence of people working in jobs that have less flexible working hours. I was actually just earlier this morning had a clinic visit with a young man who is a farmer, and he spends his winters taking care of cattle and his summers growing crops. And so his work flexibility is difficult because of the demands of those sorts of jobs, which are obviously more prevalent in our rural areas. And even those who are working in more sort of typical jobs often find hours less flexible, and the need for leave to be higher associated with this. And so with all of those factors, it's understandable that many of our young adults living in rural settings might seek their primary care providers as the primary providers of their diabetes care. And while rural PCPs are a huge resource in their communities, and it's really difficult to understate that, at some of them, and are really important to the health of rural cities and towns in general, they just realistically can't be everything to everyone, and that's not taking anything away from them. It's just they are tasked with enormous amounts of care to be given to the people in their area. So this data is from a survey-based study, which asked primary care providers to sort of reflect on their confidence in various aspects of diabetes care and patient advocacy. And you can see that those areas highlighted in orange are areas of diabetes technology and providing psychosocial care, which are areas where PCPs have the least confidence in their ability to support patients with type 1 diabetes. So insulin pumps and continuous glucose monitor interpretation being areas where these providers express the least confidence in their ability. And so it's certainly not to blame these providers or say that they're ill-equipped or not doing their jobs, but simply to highlight that these providers are often stretched very thin, and that these areas of diabetes technology and psychosocial support are really critical areas where rural providers need additional support to ensure that we're providing optimal care for these patients. And so now that we've talked a little bit about sort of adolescent and young adults and why their care is particularly important, and we've talked a little bit about rural, the sort of state of the art of rural care, for type 1 diabetes, I wanted to sort of move to the work that we've been doing as part of the K12. So the two aims of the project are really complementary. One is a quantitative aim where we're using EHR and technology-based data to better understand the barriers to technology use that are experienced by those living in rural areas. And the second aim is a qualitative aim where we've partnered with the Kansas Care Improvement Collaborative, which is a confederation of rural health clinics providing primary care in Kansas to help recruit patients to help us better understand the experience of care that young adults living with type 1 diabetes in rural areas experience, so that we can build a foundation of data which will help us lead to and build to clinical interventions to address the needs of these patients. So first I wanted to highlight a project that we finished and was published earlier this year. This was done at my previous institution, where we had roughly 20,000 pediatric patient encounters among patients seen in the type 1 diabetes program, academic program, which had had a central clinic in an urban center and then satellite clinics out in more rural areas. And so what we saw was, despite being cared for by the same set of providers who staffed all of those clinics, those living in more rural areas, small rural towns and isolated small rural towns had lower rates of CGM use compared to their urban peers. We quantified CGM use using CGM billing codes, which was nice because it not only showed us were they wearing the CGM, but did they have all of the data that was associated, that was needed for the provider to really provide care based on that CGM use. And so you can see the odds of, after full adjustment for other covariates, those differences persisted. And importantly, especially as we talk about the sort of work that we've been doing since, we also saw in a secondary analysis similar trends when we looked at quartiles of deprivation. So another approach to geographic analysis is to use areas of neighborhood deprivation to help us understand social determinants of health that may differ across geographic space. And so in our secondary analysis in this first piece of work, we showed that there were lower rates of CGM use in those two quartiles that were the most deprived. So now I wanted to move to talk about some data that we're working on now. And this is from a novel data set from a different diabetes program, which had the advantage of having a slightly larger number of encounters, 40,000 encounters, and a broader span of time. So going all the way back to 2016, where we can look back for any CGM data, not just billing codes, but whether or not CGM data was present. And we can go all the way back to 2016 and have data all the way through 2023. And so the bar for CGM use, quote unquote, is actually a little bit lower in this cohort, because all we did was require that they have one data point from a CGM at any point in the 30 days prior to their visit to sort of count it as a CGM qualified visit. And so what you can see is what somewhat surprised us, but does mirror some of the previous work. So when we look urban versus rural, we see the gap in CGM use from that 2018 to 2021 period, with those the differences narrowing as we approach 2021. And I think the first thing that we noticed was that sort of the gap certainly narrowed as we went on in time, but we also noticed that we had a plateauing in CGM uptake. So I think this really calls towards the work that Kathryn is doing, where we have persistent lack of uptake in a proportion of our patients who would benefit from CGM, but for whatever reason have decided or elected not to continue to use that. The second thing that I wanted to highlight and talk a little bit more about is sort of the way that these data are analyzed. And so when we, again, calling back to the work that Dr. Fantasia is doing, we know that that all of the people in that make up that blue line are not the same. And so especially as we saw from the secondary analysis on our initial work, we know that there are areas of deprivation and people who experience different social determinants of health, which may influence their ability to uptake CGM. And so what we decided to do was to explore whether there might be differences within that sort of urban cohort that might be important for us to explore further and might actually help us understand the experience of rural patients as well. And so, and there's a robust literature in the rural health literature that describes this difficulty with simple rural-urban comparisons, because as we can see in the data, once we stratify by deprivation, we see a marked difference among those in urban low deprivation areas and urban high deprivation areas. There's a robust literature. Dr. Agarwal, again, who did the work before that we highlighted, has done very nice work to demonstrate the role of social determinants of health on technology uptake among patients with type 1 diabetes. And we can see that not only does that impact the way that we perceive CGM uptake among those living in urban settings, but it also allows us to see the experience and differences in uptake among our rural patients. And I think this is particularly important for us to highlight because this is a situation where the interventions, again, that Dr. Fantasia is doing and many others are doing to try to address the disparities that are experienced in our in our urban population may be relevant to, but need to be adapted to the needs of our rural population. So we highlighted earlier all of the different barriers that our rural patients experience. But importantly, this is an area that where we're going to need additional work to adapt all of that great work to help bring up the patients who are living in rural settings to be able to have the benefit of this technology as well. So that's the quantitative work that we've been working on. And so now I wanted to shift to the qualitative work that we've been doing. So, the overarching, the goals that we set were to just understand the patient experience for these patients, and especially those patients who are not being seen by subspecialty endocrinologists. So how does receiving care from a primary care doctor feel, and how do the interventions that folks have taken before, both from the pediatric side to the adult side, how is that playing out in the lives of our patients? So it's been interesting to understand these data a little bit more. So what we saw was some things that we hear often from young adults anyway, which is about the importance of connection. So the first quotation there really highlights the importance of connection with doctors. The second, just the hazards and the potential pitfalls of not involving communities in the care interventions that we're undertaking. And then I think last, and the one that has really shaped the work that we're doing moving forward, is this sense that patients feel kind of trapped between the option of having a local primary care doctor who knows their context and knows their life and is easily accessible, but who may not have the specialty care, the ability to deliver the diabetes care that they want, versus an urban specialist who may be able to do, may be more knowledgeable about type 1 diabetes care, but may lack some of the context that's really important for them to be able to deliver high quality care to those patients. And so now to sort of shift and think about the ways that we're going to move this work forward in the near future. So I highlighted the data that we have from our local center. That includes CGM data, but also includes insulin pump data. So we're excited to be able to analyze that and understand how the disparities and the experience of rural communities may play out in that setting with insulin pump use. Also excited that we're expanding our qualitative work to include rural primary care providers to better understand their experience in caring for young adults with type 1 diabetes. And recently have submitted a K23 based on this work to develop and pilot test collaborative telehealth-based intervention to address the needs of young adults living in rural settings. So really appreciate the support of the folks here at KU and at Children's Mercy, as well as the DiabDocs team Dr. Dominglio, Dr. Moss, and Dr. Agarwal have been amazing supports and advocates for my work, and just really appreciate them, as well as Kamal, who is an excellent resource, and just really appreciate all of her support as well. So thanks so much, everyone, and I'd love to take any questions.
Thank you, Daniel. That was great. I just wanted to, I guess, make a quick comment that both of, yeah, it does seem that Kathryn and your work dovetail together very nicely. And it seems like, you know, I didn't know if you had, if you're aware of sort of the Risley Health Initiative with Lauren Bongiorno. She's very, I'd say, sort of social media friendly, and she has this outreach, but she does have a lot of very interesting groups and boot camps that she does. And it sort of strikes me that these two, you know, populations could sort of almost be like verticals under her umbrella in terms of outreaching to people and giving them space to connect, or maybe something totally different. But it's really, the way you're talking about sort of like people's access, you know, they're remote, or even they're somehow siloed even in a city, that it might be a great way for them to connect. And we have a comment here, connection synergy in this K12 program have been a great highlight for me. So thanks for that ad. Anyone else before we proceed? All right, moving onward to Dr. Jacob Kohlenberg, if he can just take over the slides, and thank you, Jacob. So Dr. Kohlenberg graduated from the Medical College of Wisconsin in 2015, and he completed an internal medicine residency in endocrinology, diabetes, and nutrition fellowship at the Mayo Clinic, and he joined the University of Minnesota faculty in 2021. He's a scholar in the National NIH K12 Diabetes Docs Physician Scientist Program, and he leads a research team focused on improving the care of people with type 1 diabetes. His research focus includes the prediction and prevention of diabetic ketoacidosis in people with type 1 diabetes using machine learning models and clinical intervention strategies. Thank you so much for joining us, Dr. Kohlenberg. I don't see you yet.
Oh,
Yes, now
can you see?
there you are.
Okay, fantastic. Thank you so
Great.
much for the introduction. And today
Sure.
I'll be talking about predicting and preventing diabetic ketoacidosis, or DKA, in adults with type 1 diabetes.
Great, very important topic.
Thank you. And here are my disclosures. So what's surprising to many people is that despite significant advances in diabetes technology, federal initiatives to improve access to care, DKA events remain unacceptably high in people with type 1 diabetes, particularly young adults. The annual incidence rate is about 10%. DKA, particularly when recurrent, is also one of the leading causes of death in people with type 1, less than 50 years of age. And the economic burden is substantial. In 2017, in the US alone, DKA-related hospital charges exceeded $6 billion. Therefore, preventing DKA is critical to improve patient outcomes and reduce healthcare costs. So the question is, how do we accomplish this? So let's start by talking about DKA risk prediction. Electronic health record-based models to predict DKA risk have been successfully developed and implemented in pediatric, but not in adult health systems. And I'll just emphasize Dr. David Schwartz and Dr. Mark Clements and their colleagues who have implemented successful models in their pediatric health systems. Furthermore, the use of machine learning to identify novel risk factors and their complex interactions to predict DKA remains nascent. In terms of DKA prevention, we know that structured diabetes education can address multiple DKA risk factors concurrently, and intensive behavioral interventions have demonstrated efficacy to reduce DKA events in youth with type 1. Additionally, delivering diabetes care and education via telehealth can potentially reduce DKA events in adults with type 1 at high risk. What's really interesting now is that with CGM devices, we have the capability to provide real-time glucose data sharing with a follower. And when I say follower, I'm talking about a family member, friend, caregiver of somebody with type 1 diabetes. It's been shown that sharing glucose data with a follower was associated with improved hemoglobin A1C in time and range and improvements in quality of life metrics. However, the data that investigated the use of a follower was limited to retrospective or survey-based studies or specific populations, pregnant women and older adults. And I'll just emphasize Dr. Nancy Allen has done really amazing work in this field in older adults with type 1 diabetes. So with that background in mind, my two objectives are: one, predict which adults with type 1 are at high risk for DKA, and then develop an intervention to reduce that risk. Specifically, I'm aiming to develop a dynamic electronic health record-based prediction model that will enable population health forecasting. And I'd like to leverage CGM devices to enable real-time glucose data sharing with the follower, and then provide structured diabetes education to the dyad, meaning the person with type 1, together with their follower in order to reduce DKA risk. So with that in mind, my hypothesis is that DKA is both predictable and preventable in adults with type 1 diabetes. And I'll talk through the work that I've done pursuing these two aims to date. So my first aim that I set out was to develop an electronic health record-based model to predict DKA risk over the subsequent 180 days in adults with type 1. Step one was establishing a data set of adults with type 1 diabetes. And actually, this was more challenging than you would expect. Using ICD codes alone to develop a data set is very problematic. ICD codes, it turns out, are not specific at all for identifying adults with type 1. So what we ended up doing was modifying two validated algorithms, the Supreme Diabetes algorithm and the Clompus algorithm. And this is work that will hopefully be published in the next 6 months or so. But we use these algorithms to create our data set. And between January 1st, 2017 and spring of 2023, there's about 8,000 adults with type 1 that receive care in our health system at the University of Minnesota. So once we establish this data set, the next question is, can we identify who had DKA events? In 2024, just in this summer, the ADA updated their diagnostic criteria for DKA. And so this was fortuitous timing for us because we were able to use the updated 2024 ADA guidelines to establish a very strict algorithm to identify DKA events. So using ICD codes for DKA, emergency department encounters or hospital admissions, ketone thresholds, and pH or bicarb thresholds, individuals had to meet all 4 of these criteria for us to consider a DKA event a true DKA event. And the positive predictive value of these 4 criteria in our data set is 100%. So using this criteria, we demonstrated that between 2017 and spring of 2023, 551 adults with established known type 1 diabetes experienced at least 1 DKA event for a total of almost 1,000 DKA events over this time frame. So once we had our data set established, we performed a descriptive analysis, and I won't go through the specifics with that, but I will say that we focused on 4 variables to build our initial prototype model. The reason that we chose these 4 variables are prior studies. So Dr. Mejia Otero and Dr. Schwartz built similar limited feature prediction models that were quite successful in pediatric populations. So we specifically looked at insurance status, whether or not somebody had a prior DKA event, so this is binary, number of prior DKA events, continuous variable, and most recent hemoglobin A1C. And using just these 4 features, we were able to develop and validate our initial prototype model. Performed quite well, actually. So our area under the ROC curve was 0.84, which is very comparable to other models that have been developed in pediatric populations. But the question is, right, how do we operationalize this clinically? And so this is where we really took inspiration from Dr. Mark Clemens, who's one of my mentors on this project. And we used what's called a rank order list. So I'll just talk through how we would implement this clinically. So it's almost October, right? So imagine that October 1st, 2024, the index date, we apply this model to every adult with type 1 diabetes in our health system. We rank each person from the highest to the lowest risk of having a DKA event in the next 180 days. So number 1, this is our most likely person in our entire health system to have DKA in the next 180 days. Number 2, second most likely person to experience DKA. Number 3, all the way down to number 5,000 or so, which is our least likely person to have a DKA event in the next 180 days. And then what we look at are precision and recall. So with this prototype 4-feature model, our precision for the top 25 highest risk individuals was 0.48. What this means is that of the 25 highest risk people identified by the model, about half experienced a DKA event over the 180-day prediction window. Oops, going the wrong way here. Okay, recall. So for the top 5% highest risk individuals, our recall was 0.38. In other words, these approximate 250 people were responsible for about 40% of all DKA events that occurred in our health system over the subsequent prediction window. So this model, I think, has both significance and innovation. So number 1, it enables the optimization of resource allocation for adults with type 1, and it also enables dynamic risk stratification. So specifically, by employing predictive analytics in our health system, we can facilitate the delivery of timely interventions to the highest risk individuals, which will allow for optimization of risk allocation and proactive strategies to reduce DKA risk. Because our model uses dynamic features, such as hemoglobin A1C, it will continuously adjust for variations in a person's risk over time, which facilitates dynamic risk stratification and can allow for real-time adaptive interventions. So this prototype model is really the foundation for my K23 proposal, which I'm currently working on. And this proposal will focus on enhancing our prototype model by adding additional features identified from literature review and from our data set, and we'll leverage feature engineering and machine learning techniques to enhance our model's performance, and then ultimately integrate the model into our electronic health record and prospectively evaluate its ability to predict events. I very briefly want to talk about DKA prevention as well. So currently I'm working on a pilot RCT where we're using a telehealth intervention that we've developed called the FAM intervention to reduce DKA events. FAM stands for Follower, Action Plan, and Remote Monitoring of CGM data. We're enrolling dyads, meaning the person with type 1 at high risk for DKA and their chosen follower. And over 90 days, we're providing this telehealth intervention that's grounded in social cognitive theory and uses evidence-based behavior change techniques. Over the 90 days, the dyads meet 4 times with the diabetes educator to develop a personalized action plan. During these meetings, we set up CGM data sharing with the follower, as well as glycemic alerts for both the person with type 1 and the follower. For example, we're very clear about establishing when and how the follower will help the person with type 1 troubleshoot a CGM alert For example, if the glucose is over 250 for 20 consecutive minutes, the follower will receive an alert, and the follower will then contact the person with type 1, whether it's text, phone call, in person, to help troubleshoot. We also are developing a reference guide, which is a document that contains personalized instructions, and we're educating the follower on how to implement this so that the person with type 1 and follower can work together to troubleshoot these glycemic alerts. So at this point, it's a pilot study. We're looking at feasibility and acceptability, but we're examining a number of additional outcomes such as CGM metrics, change in hemoglobin A1C over time, urine ketone data, hopefully down the road using continuous ketone data when the continuous ketone monitor is FDA approved, DKA hospitalizations, then of course a number of custom and validated surveys such as the hypoglycemic confidence scale, diabetes distress scale, diabetes empowerment scale, and so on. Our main source of data besides the surveys is CGM data. So we do have our participants wear blinded Dexcom G6 Pro CGMs throughout most of the study. And then we do collect hemoglobin A1C periodically as well. So to date, we've completed 4 dyads in the study, and 2 are active in the study. And I'll just put a plug in. We are actively recruiting. This is a screenshot from clinicaltrials.gov. And here's our flyer. So because this intervention can be done 100% remote, we can really enroll anybody who meets eligibility criteria anywhere in the country. So if there's providers or clinicians who are watching this or listening to this, who have adults with type 1 at high risk for DKA, and they might be interested in joining the study, here's a QR code that the study participant can use to contact us. You can reach us via email, via phone, or you can even email me directly. I have my email on my last slide here. So with that in mind, I'll just say thank you. I have many people to acknowledge. I'll emphasize my primary mentors, Dr. Lisa Chow and Dr. Cece Ma, and I really appreciate everyone's time.
Thank you very much. That was great. Really drilling down on the quantitative approach to prevention of DKA. Here's a question. Here's just a comment. Thanks to all the diabetes docs for your talks today. Here's a paper from this week's WEIRD that relates elements from all 3 talks today. In an Australian population, it was found that 3/4 of new onset T1D kids that presented with DKA were actually seen by a GP in the week before DKA presentation. Oh boy. With that in mind, they developed a clinical design support tool to help with early diagnosis to prevent DKA, and that paper is in there. And then from Dr. Linda DiMeglio, kudos to all the scholars. The Diabetes Docs program is now soliciting a 4th cycle of letters of intent for applications for our mentored early career development program for physician scientists engaged in research relevant to diabetes and within the scope of NIDDK, including basic, translational, clinical, epidemiological, biostatistical, informatics, health services, or health policy projects. And the LOIs are due Tuesday, November 12th, 2024 at 5 p.m. Eastern. So public service announcement there to all watching and hearing, especially watching this recording. This seems, or we've seen that this is a really excellent program. And now there's, these 2 sort of layers of cohorts to further interact with. If you want to come in and join them, please submit your letter of intent.
Yeah, I just want to say thank you to Monica and to your group for hosting these webinars. And to all the scholars. I think it was interesting. We didn't intentionally do it today to kind of cluster around the theme, but I think it was great that you guys, your talks were excellent and very complimentary. And we'll be back with our 3rd cohort's already been, they're starting this fall. Some will start in the spring. We'll come back into this again if you let us on the study. And yeah, we hope to bring more people into the program. But I think it's I think between the session that was held a couple days ago and then the one today, I think you got an idea of the scope of what our current second cohort of scholars is doing in the program. So
yeah, and we're happy to showcase the 3rd cohort, and those of you who are contemplating a 4th cohort, we do host these videos in our digital library. So you can look back on last year's presentations and this year's and get a feeling for what these physician scientists are doing. Thanks again, and in the interest of time, we're going to hop, but thanks again for all of you for your great presentations and all the fantastic work you're doing, and to the leadership of Dr. D'Amelio and Dr. Maz, who really spearheaded and began this program, which has turned into a great program, a great ecosystem.